So I hope you all had an opportunity for a decent break. I'm not sure. I've had some lunch, so I'm very perky now. I'm actually fully functional. So this session is related to early pregnancy, as you'll all see from the program. I'm delighted to be joined by my friend and co-chair, Yazan Abdallah. Yazan, welcome. Lovely to see you. And he's going to kick off the session. Yazan, over to you.
Thank you, Tom, and thank you everybody for attending today. And it's my privilege to be involved in such event. And congratulations to ISUOG and FMF for putting together such informative program. Our first session for the afternoon is by Tom Bourne himself. Professor Tom Bourne will speak to us about avoiding diagnostic error in early pregnancy. Professor Bourne, as you have all known, was the ISUOG president between 2020 to 2022, and he's currently a chair in gynecology at Imperial College London and consultant gynecologist at Queen Charlotte and Chelsea Hospital, where Imperial College Hammersmith campus is based.
Enough, Yazan. Enough. That's it. Okay.
Well, I must say he's an authority in the field. Yeah. And one of the most important topics he researched was the topic he's going to speak to us about. The floor is yours, Professor Tom.
Okay, so I'm going to talk about avoiding diagnostic error in early pregnancy. I think this is really important. As we'll come on to, but it is quite a basic talk, but one which I think needs to be given in this program. So I'm just going to share my slides. So avoiding diagnostic error. Well, certainly where we live, we've got to be very careful. If you make any kind of mistake in early pregnancy, you're quite likely to end up in the newspaper. So, and quite right too, because making a mistake, for example, over a diagnostic miscarriage could potentially end up in the termination of a wanted pregnancy. One of the other problems, particularly in developed countries, is that people now seem to know they're pregnant. These very sensitive pregnancy tests will tell people they're pregnant well before their missed period. And if you look at this data from ceciliobotomy, you can see the predicted chance of a diagnostic scan here against the gestation. And you can see that at 5 weeks, the chances of a diagnostic scan is somewhere between 10 and 20, 22, 23%, meaning that in all the rest of these patients, you're going to have to make a decision about repeating the scan or doing blood tests where there is the potential for there to be a mistake. If you go to 6 weeks, then the chances of a diagnostic scan is sort of between 40 and 50%, and even at 49 days, at 7 weeks, it's only at a maximum about 80%. So you're still looking at about 20% of women where you're having to make a decision where it's possible to make an error, as we'll come on to. Some people think you can rationalize scans. So one of the first points I want to make about not making a mistake is that people often say, well, look, if you're less than 49 days, there's no point doing a scan. So go away and come back at, say, if you like, 7 weeks. But you can see in Cecilia's data that that's probably okay. In fact, it is okay, I think, for women who have no symptoms. Because if you look here, if you have the scan at less or more than 49 days, you will miss 2 ectopic pregnancies in either group, but they had no symptoms, so probably made no difference to the outcome. But if you look at symptomatic women, and if you look at women who are scanned before 49 days in this cohort, there were 18 symptomatic ectopic pregnancies, compared to 6 ectopic pregnancies in symptomatic women after 49 days. So I think if women have symptoms, bleeding or pain, doesn't matter what their gestation, if you don't want to make a mistake, carry out a vaginal scan in any event. Don't ration the opportunity to do a scan based on gestational age. So how do we make a diagnosis of ectopic pregnancy? Well, it's based on the ultrasound findings, ideally with a transvaginal ultrasound scan. You can see this various studies, but these 2 studies, first by George Condis, and this is women immediately prior to surgery, and you would expect to visualize the ectopic pregnancy 91% of the time with very good specificity. This is sensitivity and specificity. So that's by the time you operate. Emma Kirk carried out a study where she found that in the first scan, so when you first see the woman when she walks through the door, you'd expect to see the ectopic or visualize it with ultrasound at 74% of the time, with the specificity of 98%. So very good overall test performance. So if you're making a diagnosis of ultrasound, you should visualize the mass. It's not based on saying, for example, we couldn't see a pregnancy inside or outside the uterus, so we presumed it might be an ectopic pregnancy. You should visualize most of them. Just to make a point, one thing you don't use to make a diagnosis of ectopic pregnancy is the presence of a pseudosac. Now, in most places, this has now completely been shown, not to be something that should be used, but it still lives on. And a pseudosac is where you have fluid inside the endometrial cavity, but you can't actually visualize a pregnancy. In other words, it's a pregnancy of unknown location. And you can see this paper by Carol Benson and Peter Dubélé. They found, this is a retrospective study, that if you have a pseudosac or intrauterine fluid, it is much more likely to be an intrauterine pregnancy. In fact, in their case, almost in all the cases were intrauterine pregnancies. So clearly, fluid in the cavity is not a marker of ectopic pregnancy. And this is data from Margot Pikoski, which is prospective data. And you can just go down and see that when intracavity fluid is present, it is much more likely to be an intrauterine pregnancy, as you can see here, and less likely to be an ectopic pregnancy. And if intracavity fluid is absent, if anything, is probably slightly more likely to be an ectopic pregnancy. So it doesn't mean anything that should not be used. In the UK, still, the Royal College of Obstetricians and Gynecologists, and NICE, say that a collection of fluid within the uterine cavity, a pseudosac, is a sign of ectopic pregnancy. This is not correct. So just want to point out, you visualize an ectopic pregnancy on vaginal ultrasound. You do not use markers like fluid in the cavity as a marker. That is an outmoded concept. So you do not use the pseudosac, because otherwise you get this kind of mistake. Now, when you look at all of these, pretty obviously, I think you would say these are intrauterine pregnancies. You can almost see a yolk sac here. These are images from Peter Dubélé. They're not his patients. These are examples that he's become aware of. And you can see all of these received methotrexate on the basis they were probable ectopics. And just this, just should not happen. All these pregnancies were terminated in error. This one was booked for surgical management of miscarriage, when clearly it was absolutely, this was not an appropriate management. So be careful, because these mistakes do get made, and we'll come on to treatment with methotrexate in a moment. But if you're using methotrexate, you have to be extremely careful, because every year there's plenty of legal cases relating to methotrexate embryopathy. And you can see here, I think this is a sensible move which was made some years ago now, that systemic methotrexate might be suitable to treat tubal ectopic pregnancies, or indeed other ectopic pregnancy, but it's absolutely essential to exclude a viable intrauterine pregnancy first. And it shouldn't be given at the first visit. In other words, when you see someone with an ectopic pregnancy, as long as they're stable, because that's clearly they have to be stable if you're considering methotrexate, you bring them back in 48 hours and look at the change in HCG over time in order to make sure that you've excluded an ectopic pregnancy. So you don't give methotrexate at the first visit. The other point they make is that expectant management in clinically stable women is actually a perfectly reasonable option. And you'll find that in a number of women who perhaps you would have given methotrexate, you'll see the HCG will decline over time, and methotrexate is simply not necessary. So if you like, there's no need to make that intervention and take a risk. So if you're considering methotrexate, a scan, I think, should also always be checked by someone senior, or by a second operator, and make sure that HCG, i.e. the HCG ratio, is not compatible with a possible intrauterine pregnancy. And just remember that quite low rises in HCG have been associated with viable pregnancies. So take great care with methotrexate in order to avoid an error. Pregnancy of unknown location. So what is a PUL? It's when you do a scan and you can't see a pregnancy anywhere. You manage patients based on triaging them to low risk, which means they're a failing PUL, so you never know where the pregnancy was, or an intrauterine pregnancy versus high risk, which was an ectopic. We don't actually need to know the location, and management is safe if you have HCG follow-up. But often the management is very chaotic. People have blood tests the whole time or repeat scans constantly, and there's no clear, strict protocol. Now, there are a few things to say about HCG levels where mistakes are made. These are a large number, 1,900 pregnancies of unknown location. The purple are the ectopics, the yellow are viable intrauterines, and blue are failed. And this is an example case here. So let's just look at some of these myths. First of all, it has been said that if you have a serum HCG over 2,500 and you can't see anything, in other words, you can't see an intrauterine pregnancy, then it must be an ectopic pregnancy. Well, you can see here there's clearly a lot of viable intrauterines with a single HCG level over 2,500, and it's probable that the pregnancy hasn't been seen because they have an axial uterus or they have fibroids or some other technical reason why it's difficult to see. But you certainly can't say that it must be an intrauterine. So you can't make a diagnosis of ectopic or presume an ectopic when you have a high HCG. And in fact, the higher the HCG, in my experience, the more likely it is to be a failing pregnancy, and again, where no action is necessary. The other end of the scale is saying, well, you have this cutoff or, discrimination zone. However, whichever way you look at it, if the HCG is over 1,000 and you can't see a pregnancy, then clearly, yes, there are some ectopic pregnancies, but there are a large number of viable pregnancies. And when you look, most ectopic pregnancies are in this box here, where the HCG is less than 1,000. So this discrimination zone is outmoded, and you simply can't use it. So it's not helpful. If you put cutoffs in and you say, well, 50% rise, you can see again, this isn't actually doing a lot. And even with a 20% drop, you still will have the odd case of an intrauterine pregnancy. So great care has to be taken, but I would just implore you, do not use discrimination zone. Discriminatory zone is an outmoded concept. Single measurements of HCG are unhelpful. If you are going to look at HCG levels, use a two-step approach. Measure the HCG and progesterone. If you can do that, now not everyone can do that, but if the progesterone is very low, then this is a failing pregnancy, and you can just do a urinary pregnancy test at 2 weeks. For the rest, you measure a second HCG at 48 hours, and you use the M6 logistic regression model, which incorporates the initial HCG, the initial progesterone, and the HCG ratio. And this will tell you whether it is high risk of ectopic or low risk and determine the management. High risk, you repeat the scan in HCG at 48 hours. Low risk, you can scan in a week if you think it's viable, or just do a urinary pregnancy test in 2 weeks. Sorry, that's the most sensible way of doing it. And you can access the M6 model from this website. Just to give you some data, you can look at all of these different ways of progesterone, two-step protocol. You use the two-step protocol with progesterone. You can see that 62% of PULs will be classified as low risk, has a negative predictive value. So if you say there's no ectopic, it's 91, it's 99%, and the detection rate for ectopic pregnancy is 92%. There is a false positive rate of 31%, and they will go forward and have further investigation as well. So this is the most effective way of managing PUL. This is a situation where you have to make a decision, and there are risks over not following up patients properly, or in some cases even giving methotrexate for no good reason. So you can use this in an app where you put your HCG and progesterone in. It will tell you the risk of ectopic pregnancy. And just remember, you can also use point-of-care devices as well in some environments where you can get an HCG literally within 12 minutes. I think these point-of-care devices will become increasingly important in relatively low-income countries where you can use them and avoid the use for a large laboratory setup. Okay, getting into the final end of the talk now. Another area where mistakes can be made is in the diagnosis of interstitial pregnancy, as you can see here. And the problem is we don't have good data. If you look here again at guidance in the UK, they talk about the interstitial line, they talk about less than 5 millimeters of myometrium, talk about using 3D ultrasound, but there's very little data to back this up. Now, I think it's correct, probably, but you do have to be careful, and I'll show you why. If you are able to do a 3D scan, this is the classic situation. Here's the endometrial cavity, and you can see here there's an interstitial pregnancy. And when you look at this image, it doesn't look quite right, does it? You think, well, this doesn't seem to be in a cavity, it's very lateral. Is it an interstitial pregnancy, or is it an intrauterine pregnancy? When you do this, take this patient and do a 3D scan, you get this picture, and this pregnancy is up here in the angle of the endometrial cavity, and over time it will grow into the cavity. So this is not interstitial. In the same way, this is not interstitial. But the problem, of course, is that that's clearly interstitial, or this one, but it's a bit more difficult if the pregnancy is located up here. And so, as I said, great care must be taken when these pregnancies are located towards this angle, towards the cervix, or over, partially in, or through caesarean section scars. And you can see how when you look at caesarean section scar pregnancies, these are likely to have slightly different outcomes. And so whilst I just want to implore you to be careful with interstitial pregnancy diagnosis, diagnosing scar pregnancies is also problematic. We've seen previously various ways of diagnosing scar pregnancies, but this is not particularly helpful because it hasn't been properly tested or validated, because it suggests the list of it's a list of criteria that can be used to diagnose scar pregnancy. I think we've now got a sensible approach. This has been published by Judith Hearn's group, and this is a Delphi sort of consensus paper published in the White Journal. And you can see here it talks about having the serosal, this intracavity line, and then you have the serosal line. So you can have a pregnancy where the largest part of the sac crosses the uterine cavity line. You can see where it's not crossing the serosal line, where it does cross the serosal line in terms of the diagnosis of scar pregnancy. And I'd suggest you read this because you can see this is likely to be associated with different long-term outcomes. And here's some examples mirroring that. You can see here there's a serosal line, the intracavity line. The pregnancy is mostly sitting here, and this is where it's coming bulging through the serosal line, crossing the serosal line and towards the bladder, where the outcome is much more dangerous. However, for most of these, it's simply surgical management. So you'll be very careful in counselling women about the outcome for these types of pregnancy. So at 14 weeks, treatment, or less than 14 weeks, the treatment for these is ultrasound-guided suction curettage with a suture inserted if they're over 8 weeks. But clearly, when you get to this stage, it becomes more difficult and requires careful consideration. And you really want to try and set up regional centres to manage these because they can be extremely challenging. Finally, diagnosis of miscarriage. I just want to raise this study. This is carried out by Jessica Preiser. I just want to illustrate why you've got to be careful, because I think the assumption always was that diagnosing miscarriage is easy. In this study, if you look, this is the old criteria to make a diagnosis of miscarriage. And you can see this is in the United States. In those days, mean sac diameter of 16 was the diagnosis of miscarriage. But you can see there's a false positive rate, which means that 1 in 30 times, that was incorrect. And in the UK, it was 1 in 200. So this is a major problem and would lead to the termination of wanted pregnancies. And that's for mean sac diameter. And that's why we have new criteria now where you use 25 millimeters as a cutoff, because with very tight confidence intervals, there's 100% specificity, unlike before. However, we were merrily going along, probably making a lot of mistakes here in the past. And we get the same 5 millimeters was the old cutoff, and you can see there's a like possibility of getting it wrong 1 in 28 times. 6 millimeters, it's 1 in 100, still unacceptable. And now we have 7 millimeters, where it's 100% specificity, again with tight confidence intervals. That's why you have to take care. So if you're making a diagnosis of miscarriage, say it's 25 millimeters for a mean sac diameter or 7 millimeters for an embryo, always have it checked by a second operator, both to check the size and also, for example, for the presence or absence of an embryonic heartbeat. And have a low threshold to simply repeat the scan at an interval. Make sure that the people carrying out the scan are appropriately trained. And as I said, ensure that you review with an experienced operator. So the next problem when you're diagnosing miscarriage is how long do you leave between scans? So if you look at the current guidance in NICE and the college, basically it says that if the mean sac diameter is less than 25 or the embryo less than 7, repeat the scan in 7 days. But the thing is, there's no data to support that, or there was no data to support that when this guidance was made. And if you look at our data, or the PRISE data, you can see it's reasonable to do this. If you have an embryo without heart activity, and there's still no heart activity 7 days later, it's a miscarriage. So if there's just an embryo with no heartbeat, you can bring them back in 1 week. If, on the other hand, you have an MSD, or mean sac diameter of less than 12, then you need to bring them back in 2 weeks. I personally think it's generally safer to bring patients back in 2 weeks for all mean sac diameters to be 100% certain there's no possibility of a viable pregnancy. Now, it's unlikely as it would be that the pregnancy will be viable. But I think for a woman, it is reasonable to expect that the chances of error is absolutely zero. So that's a quick run through, just imploring people to make sure they take great care in early pregnancy. And just remember that this is, I think, a reasonable quote, that all pregnancies deserve the same level of competence, same diagnostic criteria, the same care and compassion. And I remember Stuart Campbell, I think, said this in a review of a case, said the death of an early pregnancy should be regarded as of equal significance to that occurring in a later stage. Because, you know, if you get it wrong with these early pregnancies, the potential is to get it wrong and terminate what would be a wanted pregnancy. And, actually, this is my wife here. So there we are. So I think we'll leave it there. I hope that's been useful. Obviously, I mean, early pregnancy care has moved on very significantly, but across everything you do with diagnostic ultrasound, it's a fantastic tool, but it's also the potential for harm is significant, and nowhere is the potential for harm greater than in early pregnancy. Okay, thanks very much.
Thank you very much, Professor Tom Bourne, for this informative talk covering potential diagnostic errors in the area of ectopic pregnancy, pregnancy of unknown locations, cesarean scar pregnancies, and of course the diagnosis of miscarriage. I'll hand over again to you, Tom, to introduce our next speakers in this session.